By using AIs is wrong eventually.
The difference between a medicine and a poison is typically the dose.
Exactly, dose.
I mean, that's really what it comes to.
We can probably get the blood pressure down with diet and exercise. No, I would have to treat the high blood pressure while I had them on the other things to start working.
There is no prostate cancer cause that is in any way linked to testosterone.
So the main criteria is to be physically and mentally healthy, not just be having a six-pack.
The terrible thing about the AI is then you're always kind of chasing your tail.
I think estradiol has been demonized for it's causing this and causing that, where a lot of benefits of testosterone actually come from estradiol.
Some of the physique sports, you're seeing a lot of young athletes passing, and it's very, very troubling.
People living in Colorado, in Nairobi, in Tibet, or even in Mountain Olympus in Greece, that would have to be phlebotomized and would die from strokes.
I definitely agree that sleep apnea is a huge player here, and it's really common.
It's interesting that we're talking about the weight loss because the European Society of Endocrinology, in part of their guidelines, say if you have an obese patient that perhaps they ought to do lifestyle changes, lose the weight, and then consider testosterone. The UK doesn't. You can go straight to testosterone treatment because, again, I think they recognize hand in hand. But there's been some recent data around GLP-1 agonists. Possibly, if you can decrease your weight, you may be able to increase the testosterone level. So I want to know what the panel thought. Do GLP-1s have a role in improving testosterone levels, or maybe they're best used in combination, in conjunction with testosterone treatment? What would you do for a patient if they came in and they're a bit obese? What would be your approach, and what do you think about that study?
So I think, as with everything, it depends on their situation, their lifestyle, their goals. I think they can be helpful to obviously lose weight, which, yes, is if you drop weight, especially the visceral fat, you can improve your testosterone, improve a lot of your other hormones. But it's a case by case, because the biggest thing I would want to put in place is, number one, they're not using it as a crutch or as a cheat if they're not going to do the lifestyle. We see that a lot where people just want the testosterone or they want the GLP, but they're not willing to give up the McDonald's or go to the gym. Well, you got to do everything, or it's not going to work. But it can work. But at the same time, I think the hormones are foundational. Oftentimes, I think if you're going to add something, that should be added first before you go to the GLPs. But as George said, I think there's a time and a place for both of them, for sure. But the other reason I said it depends is also on the situation. If someone is, can they go to the gym and eat healthy and lose some fat, build their testosterone? Yes, but a lot of people are so far gone, or they're so far, I've seen guys and women where they're just so, their motivation is in the floor. They have no energy. No, they're not sleeping. They feel like absolute dog crap, and there's no way they're going to go to the gym. So sometimes we'll do a full court press and optimize their hormones, maybe do a GLP and hit them everything, because otherwise they're a metabolic nightmare. They're a heart attack waiting to happen. If you look at their labs and their lifestyle, and they're miserable and their inflammatory markers are through the roof, they need everything to get them on track. And then maybe we can peel some things off later, especially if they're younger or there's something causing that. So again, it just depends on the situation.
I think to look at it, like, I'm going to wait and see if you lose this fat and then put you on testosterone would be a lot like if a patient came to me with horrible high blood pressure. And I said, well, we can probably get the blood pressure down with diet and exercise. And I just waited for the diet and exercise to start working. No, I would have to treat the high blood pressure while I had them on the other things to start working. So I would say that I'm not going to do the same thing. If somebody's coming in and they've got visceral fat and they're eating crappy, I'm not going to say your testosterone will go up just by doing that. I'm going to encourage that while I give them testosterone, which is going to help all those other things, help them do all those other things, right? So I think we do that a lot in medicine, where we say, oh, you can control us with your diet and your exercise, and ignore the fact that we have to treat the problem at the same time. You have to bring it all in at the same time.
Speaking of blood pressure, I think recently the Traverse study came out, which is a very large study that looked at the safety of testosterone in men, because that was still a question, unbelievably, since testosterone's been around for 100 years. But they finally did this large study, and off the back of that, I think the FDA took off the black box warning around with a small caveat about potentially just monitoring blood pressure when first starting. On that note, I mean, what do you think is the ideal treatment modality? Because some have argued that the Traverse study was using testosterone gel, And we, in modern TRT, use microdosing, usually of injections, possibly topical scrotal creams. And then is it appropriate to have other adjuncts for managing blood pressure, particularly in maybe male patients, middle-aged male patients who already get a breakdown of their angiotensin receptor system? I mean, is that a proactive approach as well? Because obviously testosterone can improve blood pressure overall, you know. But is that enough? And are there other adjuncts that should be used, from the both longevity and the generalized health?
Yeah, so Dr. Hetok says that optimization of testosterone, normal dose, not abuse in testosterone, will cause vessel relaxation through the nitric oxide, and this vasodilation drops the blood pressure. But if you have used, obviously, as any other steroid, you kick aldosterone, that retains sodium and water as a result, and then you have the elevation of the blood pressure. So more is not better, of course, and you need to find the optimal dose in order to avoid the polypharmacy.
What about some of those maybe young men that do start on TRT? You see it sometimes. They may have initially a bit of water retention, and because all androgens can cause the fluid retention or mineral. You hold on to certain minerals. So, I mean, is there something that you just watch and wait? What's kind of the approach of some of the doctors on the panel?
Yeah, I think that if you're getting side effects, probably you should back down on dosing and then dose adjust from that. Certainly watching diet, sodium intake, things like that to regulate aldosterone levels. But I would say that when I see a side effect, when somebody is getting a whole lot of edema, something like that, then probably I need to dose a little bit more appropriately or change my dosing regimen a little bit on them. I think sometimes you can, use dosing microdosing a little bit differently to get them better when you see that. Because to me, that you're treating a side effect now with something else. I think that side effect is indicative of the body's not doing as well with that dosing. You probably need to adjust the dosing on that.
Just even outside the medical context, as the layperson here, the difference between a medicine and a poison is typically the dose.
Exactly, dose.
I mean, that's really what it comes down to. And so I have clients who are on testosterone and cornucopia of other performance enhancing drugs outside the medical context. And the difference between 100 milligrams or 200 milligrams a week of testosterone cypionate and 2 grams a week of testosterone, or in some people I know, 5 or 8 grams of testosterone per week, you're going to get, if you're using it purely for physical enhancement, you're going to get more bang for your buck out of those sorts of doses. But that's where you really see the side effects start to mount. And you may have seen, if you follow some of the physique sports, you're seeing a lot of young athletes passing, both male and female. Right. And it's very, very troubling. So yeah, it is dose dependent. But we've sort of dumbed down historically in our sort of anti-testosterone messaging and agenda, as George says, kind of claiming that testosterone causes roid rage, or testosterone causes prostate cancer, or testosterone causes heart attacks. Yes, there was, as far as I saw, there was never a shred of evidence that would have supported that black box warning. And I used to write a column for Muscular Development magazine for many years, and I did a few columns on why that should never have been on there. And it's nice at least to see now that it was taken off. And it's also nice to see now that there's a concession that there is no prostate cancer cause that is in any way linked to testosterone, certainly in replacement doses. One of the things that I wanted to kick around with you guys, and that I was chatting with Mike and George about yesterday, was the use of aromatase inhibitors in the context of testosterone replacement. And is that a good thing? Is that being overly used? Or is titrating dose and avoiding the use of a drug to treat the side effect of some other drug a better way to go?
Yes, unfortunately, there's a misconception between bodybuilding and TRT. And unfortunately, many people want to get into TRT just because of physical enhancement. And this is when doctors freak out and say you're just a bunch of bodybuilders that want to get jacked for a lifetime. So the main criteria is to be physically and mentally healthy. not just be having a six-pack or a 20-inch arm or bench 400 pounds on the gym. So speaking about AIs, I was using AIs until 5 years ago. Later, I dropped about 20 pounds within a year, and I realized that my nipples didn't hurt that much, presumably because I had less body fat that converted to estrogen. Now, I find it more healthy occasionally to use a serum in order to occupy the receptors and don't kill the production of estrogen, because estradiol is fundamental for joint health, for bone health, for endothelium health, for brain health, for libido. And testosterone is a fundamental hormone because it breaks down into two metabolites, DHT and E2. That's why you cannot replace testosterone with any other hormone. We need E2 as much as we need DHT. And I think by using AIs is wrong eventually. Now, you may occasionally use a fragment of AIs just to treat the symptom, but not on a regular basis, because you end up having deficiency of two, cracky bones, low HDL, moodiness, they kill your sex drive. And we've seen this with bodybuilders that want to look dry just by killing the E2.
Well, I was going to say the benefits of not having to use an aromatase inhibitor are manifold. And there are some dysregulation in mood when you drop the E2 too low. There's dysregulation in sensitivity, in your penis. But you can also have some men, and this is where I think there's a couple of papers written that are outliers. And obviously dropping the dose is ideal, but I was just wondering what the doctors thought about some of the outlying cases of men who, even when you drop the dose to optimal, who may still have things like venous leakage. And there have been a couple of papers that linked the absolute level of estradiol to the venous leakage, and when that was corrected, it improved the erectile function for the man. And is that a worthwhile endeavor, provided that the estradiol doesn't drop too low? Obviously, the terrible thing about the AI is then you're always kind of chasing your tail. But could a small amount of relief have any efficacy? I know I've seen endocrinologists have it prescribed for me in the past, and way too much in the past, where it would defeat all the benefits of testosterone converting to estradiol, where you get the boost in HDL, you get the boost in mood. So I don't know. I mean, everyone's different, I think we talked about, but is there ever a role in the least amount of time, or the least amount that you could use that you may fix a symptom, maybe in midterm before you can get the dose adjusted?
There's always exceptions, but for the most part, I rarely use estrogen blockers or AIs. I feel if you look at the data and the studies, it's very clear that if you do that, especially chronic or long-term or high dose, it's detrimental. It causes osteoporosis, erectile dysfunction, and accumulation of visceral fat. I think estradiol has been demonized for its causing this and causing that, where a lot of benefits of testosterone actually come from estradiol, the fat loss, the sexual function, and so on and so forth, especially in men. So I would love to say never use it, but there's always exceptions. I have one patient in particular who occasionally gets some nipple issues, and I've treated him with Clomid and with AIs just for literally a week, and it's better. But across the board, most of the time you could just adjust the dose, or there's something else going on that has to be addressed. But I think in general, I rarely, if ever, block it because it's just detrimental. Estradiol has many, many beneficial effects on men and women. We can get into more of that later. But again, there's always exceptions. There's people that just respond to certain things better. But if you are going to do it, it would be very low dose, very short term, and then that's it. But typically, managing lifestyle, other nutritional deficiencies, lifestyle factors, dose adjustments, you can get exactly the same thing without the detrimental effects.
I just want to add to what you were saying, Mike, is that so typically even a very high estrogen dose, people will not become symptomatic, or high estrogen levels don't have nipple sensitivity, don't have venous leakage. But the caveat is how you are metabolizing that estrogen, because a lot of times it will be metabolizing into what's called 4-hydroxyestrone. This is a very strong metabolite, also much more linked to things like prostate cancer, oxidative stress. So you do have to sometimes, in those people who are symptomatic and aren't doing what you think they should be doing. If I run testosterone high, I run estrogen high. So if the person's having symptoms from that, I need to look at how they're metabolizing it and then work on optimizing the metabolization. So using things like maybe diethylmethane to stop some of the production of 4-hydroxyestrone, or calcium D-glucarate to eliminate the 4-hydroxyestrone. because typically it's not the estradiol itself. It's one of its more toxic metabolites that's creating the problem. So that's when I see somebody who's having symptoms from a higher estrogen, I look down a little farther down the chain.
Calcium deglucarate, because there are some studies that are very promising against, well, basically animal studies, we don't really know, or cellular studies against maybe prostate cancer or growth, maybe due to that estrone. But what about if someone's on thyroid medication, or will you not then absorb, or will it not kind of block the absorption of the other medications? Because it almost works as a binder, does it not, the calcium deglucarate?
Really binder. It's acting to increase glucuronidation, which is your way of getting 4-hydroxyestrone. Will you metabolize thyroid a little bit faster? Possibly, which if that's the case, you may have to adjust your thyroid dose. So you have to watch those things. It's still, glucuronidation is critically important to our detoxification pathways. So if somebody is showing that metabolism, you're going to do benefits by improving that with a simple supplement.
I'm going to tee another one up for you guys. Hematocrit, polycythemia, and erythrocytosis. Go.
So I would be dead now because 10 years since I'm on TRT, the last decade, my hematocrit range is, it's steady to 55%. Now, there are two reasons, there are two cases of elevated hematocrit. And actually, we should see hemoglobin, which is more reliable marker, because hematocrit obviously elevates from dehydration that leads to pseudo-elevation by concentration of the plasma. So either we have polycythemia vera, which is a genetic mutation in the JAK2 gene that elevates both red blood cells and thrombocytes known as platelets, and this is the risky factor. I had 2 cases of polycythemia in my career, and it was around 500,000 to 1 million of platelets, and of course a hemoglobin of 17 or 18, and this guy of course had to be phlebotomized. But as the late John Chris has said, the low platelets is the key number. In my case, I have a hemoglobin ranging from 17 to 19. And what I noticed is this: when I go for a blood donation, my platelets elevate. And when vice versa, when I don't blood donate until 3 months, for instance, my hemoglobin elevates, my platelets go down. This is a compensation from the red bone marrow that lowers and tries to give a balance, lowers the platelets when the hemoglobin elevates. Now, secondary erythrocytosis, which is either by testosterone, by sleep apnea, by high altitude, and by smoking, does not increase the platelet number. If that was a problem, then people living in Colorado, in Nairobi, in Tibet, or even in Mountain Olympus in Greece, they would have to be phlebotomized and would die from strokes. So I believe there's a compensation, but definitely when you're erythrocytotic through testosterone, you need to check out your sleep apnea. As Ron McLean says, most of the patients, because they heavy lift, they develop a thick neck that perhaps leads to obstructive sleep apnea. Absolutely do not smoke. I don't let my patients that need to go on testosterone to smoke. I tell them choose between smoking and testosterone. And of course, you can use an aspirin that will deactivate the platelets, all right, and improve the blood flow by decreasing the clotting.
Like with pentoxifylline or
pentoxifylline also improves the blood flow, and fish oil also, because some people have the G6PD intolerance and they cannot tolerate aspirin, so they use the fish oil instead.
Now, I want to talk about not every time, and maybe you guys have seen this as well, on the blood test if you look at just hematocrit, I think in most labs is a calculation of the mean cell volume times the red blood cell. And depending on how those labs are processed or how long it takes to get them to the analyzer, then you can have almost a swelling of the mean cell volume. So that means the cells get a lot fatter, but they just get bigger, they get measured. And that goes into the calculation, which then skews the HCT. When we see hemoglobin on our labs, that's usually, the question is, elevation of hemoglobin, is that due to the sleep apnea? But how do you discount or look at maybe the red blood cell in combination with maybe the dehydration issues before you jump on to trying to remedy it?
I definitely agree that sleep apnea is a huge player here, and it's really common, much more common than you guys think. So if somebody's running with a high hemoglobin hematocrit, typically I will run a test for sleep apnea, and 90% of the time that will explain the problem. I think that completely agree with George that a hemoglobin hematocrit increase due to testosterone, just like living at high altitude where I do, is not detrimental to health. But when you see it in conjunction with other factors, when platelets get very high, things like that, but then there is almost always something going on. Testosterone in itself is not the cause of this. So you always have to look deeper down the chain when you see these people who are having pathologies instead of just blaming testosterone. There's no evidence at this point that testosterone causes blood clots. I just had a conversation with somebody about that. It's fibrolytic, exactly. It actually reduces
fibrinolysis. That means, unlike the anabolic steroids that secrete also fibrinogen from the liver, testosterone is a different class. So it's fibrolytic that makes breaking the thrombus.
So I agree with everyone what they said, and a lot of the newer studies are showing that like the people who phlebotomize too much or too frequently can actually backfire and make things worse, and which is not what you want. So there's no need. And as George said, people living at altitude, people that smoke, they're not dropping of clots. The main confusion is this, like you said, a lot of physicians and people confuse the erythrocytosis, the elevation of red blood cells, with polycythemia, which is an autoimmune condition, two completely different things. And like Betsy said, I agree. Sleep apnea is huge. It's very common. I mean, I have mild sleep apnea. I never would have thought that years ago. I did it, but if someone it's elevated. If you rule out sleep apnea, if anything, yeah, you can lower the testosterone dose if you have to. But most of the times you don't need to do that, and you definitely don't need to phlebotomize. I think that's overdone. But I agree with Betsy that screening for sleep apnea, screening for chronic venous insufficiency, these are some things that can easily be done. Unfortunately, nowadays it's a lot easier. You don't have to go to the sleep lab with all these clunky things. They have some new things that you just put a ring on, a thing on your forehead, different things.
What is the screening for sleep apnea now?
Sleep study, but they have the newer devices that can measure so many different things now.
Yeah, there's two companies we use, one called Vivos, one called Empower, that actually is just a little ring you put on at night that actually, and they have more detailed sensors too, where you can put a little sensor on your legs, and they give you a really detailed analysis. But just a little ring analysis is huge. Even your Oura Ring, by telling you how many sleep disturbances you had. If your Oura Ring's recording a fair number of sleep disturbances, likely there is a problem. The Oura Ring's not all that sensitive. If it's picking things up, your Oura Ring says, we detected 15 sleep disturbances last night. Probably you should be tested for sleep apnea with a more detailed study.
Also now then, when you are looking to diagnose a patient, how important do you weigh some of the sexual function issues versus other metabolic issues? I mean, we have the Adams questionnaire, and some of the big hitters are, loss of morning erections, loss of desire or libido, but then other parts of the questionnaire ask about, loss in your performance at work and deterioration in your performance in your sport, falling asleep after dinner. So where do you put more emphasis on the sexual? And I think the same thing for women, because I know some of the guidance talks about, if females have libido issues, then that's warranted to prescribe testosterone. But what about the other benefits in the urinary tract for women as well, or other just health and metabolic benefits of testosterone across the board? How do you rank those, and how do you make a decision to treating?
I think sexual wellness is huge, right? So it's gonna rank awfully high in my decision making. With women, men testosterone plays a huge influence in libido. In women, it's a much smaller player. So women always who have low libido think, I'm going to fix them with testosterone. It will help, but women's libido is much more complex because there's a lot more brain involvement in women. And so women's libido is much, much more complex, and why we're looking at drugs like Vyleesi and things like that actually are working on more dopaminergic centers in the brain, because women are much more complex. And I would say only about 20% of my women can I fix their libido and orgasms and things like that with simply testosterone. Stress plays a huge role. Women's brains are much bigger players here. Men are pretty simple, and in general, right? Men are just easier than women, much less complex. But most guys, you can do pretty well with improving libido and erection quality by optimizing testosterone. Women, it's a little more difficult.
I'm glad Betsy said that women are more complex than men, because if I said it, we all know that, right?
Canceled.
So much more to it. So women are tough. But I agree with Betsy 100%. With women, yes, it's very multifactorial. But with men, it's also important, not so much because of that, because it's the canary in the coal mine. A lot of guys they'll have this issue. They won't say anything, right? Oh, I'm fine. But as soon as they have a problem down there, they're coming to their doctor, right? So sometimes that's the only way we can get to them. But it's also, again, a harbinger. It's like it's about vascular health. People have probably heard that if they're having erectile dysfunction or any issues, that's affecting their blood vessels. Well, it's probably affecting their blood vessels in their heart, their eye, their brain, everywhere else. So it's a vascular condition. We need to look at their overall metabolic health and fix it, not just the erections, but everything. So sometimes it's a very important thing. It's a telltale sign. But on the flip side, a lot of people go the other way. They think, well, my sex drive is down. It must be my testosterone. Well, it's sometimes, but it's also usually other things, because I see a lot of guys and women, their testosterone levels are great, but their sex drive is down because it's other issues. It's like Mike talks about dopamine, stress, psychological factors. Libido is affected by so many things other than testosterone. So that's where the whole evaluation comes in, the more of a comprehensive approach. It is very important, but it's not the only thing for sure.
I believe things to watch out on the low sex drive. We need to check out prolactin, the antagonized testosterone. We need to check out also SHBG in the relation to the free testosterone. So by optimizing prolactin, we increase the amount of testosterone. And high prolactin gives you an orgasm, meaning you cannot come into an end. And of course, too high SHBG does not let the bioactive free testosterone to work. So by managing SHBG, the use of DHT derivatives, even synthetic DHT, or even increase the dose of testosterone, you can liberate more testosterone. Do not kill the estrogens, because low estrogens kill you to sex drive. And also HCG is a libido enhancer, I believe, because it can increase also your estrogen, but increase also your intratesticular testosterone, and this will increase your libido. Okay, so many people on antipsychotic drugs or SSRIs, they have a prolactinemia, and some of them are destined to go for an MRI, but most of the cases it's not prolactinoma, and also insomnia and stress elevate prolactin as well.
I mean, maybe we should talk about some of the dangers of even mildly elevated prolactin, because it can almost be a harbinger of negative vascular health, or even leading to higher lipids, and it's just not ideal. If you sometimes give a dopamine agonist, you improve the vascular tone, which is very interesting, not to mention some of the desire. I wish we had better tools, but one of the things that we would see in the clinic from time to time is that you'll have, especially men will start the testosterone in the first early days as the pituitary switches off, the LH-FSH switches off. You do see a mild rise in prolactin, decently high though, and sometimes it affects the libido, sometimes it doesn't. Have you seen this in practice? We found it more with those who were on the SSRIs, either in the past or concurrently. I just want to see what you guys have found.
So we do measure prolactin in everybody. I think it's an underutilized tool because it does play a big role in erectile function and sexual desire and a lot of things, not to mention a lot of other problems that occur. So we do measure prolactin in everybody. You will sometimes see a transient elevation, and it usually should stabilize. There's a lot of supplements along with your everybody's on SSRIs, but there's also a lot of supplements that now people are taking that have a big effect on prolactin. So you have to be careful. Some of those supplements you're taking, even ashwagandha, can actually raise prolactin levels a little bit in some people. So you have to watch it and be a little cautious. And I think prolactin level is something that's underutilized and undermeasured. Most people, it's not on your standard protocols, right? And I think it's useful to watch and keep an eye on, because its changes can be. You want to keep it not too low, not too high, but somewhere in the lower mid-range.
What do you do when, at least on the libido side, when testosterone isn't enough? I think some of you guys have addressed it. I know there are other tools. And what other hormones do we sometimes add in? I mean, just getting back to the prolactin, I mean, one of the signs of high prolactin might also be low thyroid issue, high TSH, etc. But we can talk about that and some other tools or other thoughts, DHEA, that might help, and DHT.
Yeah, it can be very complex. So some things that are forgotten, I think the biggest ones, of course, like we talked about, are like psychological stress is probably one of the biggest ones. Everybody's stressed today. Cortisol is high. Or staying up all night, blue light. And I talked about circadian rhythms earlier today. This is a huge, huge factor. But in terms of other hormones, yes, DHT is very important for this. Estradiol is important for this. DHEA and pregnenolone, all the precursors. Sometimes if someone's put on testosterone, but you don't replace some of those pre-hormones, that can have an effect. Oxytocin is often forgotten about sometimes, and that can be improved and can improve sleep, inflammation, mood, sex drive, orgasmic function. And you can do that just with simple things naturally, with touch, intimate touch, cuddling, eye contact. You can actually give oxytocin as a prescription, as a nasal spray or injectable. Sometimes that's forgotten about. Melanopsin, melanin stimulate, MSH. This can affect mood and energy and drive and libido. And just again, talking about getting out in the sun, optimizing your circadian rhythms. People have prescribed things like the PT41 and melanotan, all these other peptides, but you can do it naturally as well. And of course, thyroid, as you mentioned, is very important. Thyroid affects everything in the body, and oftentimes that's the missing piece. If that's not optimized, that can affect sex drive, it can affect brain function, stress, depression, and so many more things. So it's not just testosterone, it's all these things. It's why it takes sometimes a little bit of digging to figure that out.